And Celine is a senior and a passionate pediatric oncology nurse, lead and educator from Kenyatta National Referral Hospital. And this is what is the largest hospital in Kenya. And she has over a decade of frontline experience in taking care of children. And she has led multiple transformative quality improvement initiatives in chemotherapy safety, supportive care, and nurse training. Additionally, Celine holds a master's degree in oncology nursing from the University of Nairobi and is very invested in strengthening cancer nursing capacity across low resource settings. She's very passionate about creating sustainable change in childhood cancer care and ensuring every child receives dignified, timely, and high quality treatment. Let's welcome Celine as she's going to take us through how to handle pediatric oncology emergencies using a multidisciplinary approach. Welcome, Celine.
Thank you so much, Joanne, for the introduction. I'm really grateful to be here. Apologies, I hope my sound will be, I hope I'm audible enough. Can you hear me?
Yes.
Okay, apologies. I'm actually at work and we have visitors who are visiting the children. So you might hear the background, but I hope you'll be able to hear me. In case you won't, you'll just let me know so that I can increase my volume. Okay, so this is our presentation for today. It's a nursing case study. We may move on, Aisha. Thank you so much. So my presentation today is on a Burkitt Lymphoma patient whom we had earlier this year. And we were able to work as a multidisciplinary team in order to try as much as possible to stabilize the patient and give the best that we could. So I just wanted to introduce Burkitt Lymphoma as a condition, which is a highly aggressive B-cell malignancy with extremely rapid proliferation and a high risk of tumor lysis syndrome, which I believe most of us have been able to encounter. And the risk factors is strongly associated with Epstein-Barr virus, which is quite common in this particular endemic region. Also, malaria exposure is one of the risk factors, of which Kenya happens to be an endemic area, and also immunosuppression for patients who have HIV. And for the diagnosis, mostly it's usually through the clinical features with the rapidly enlarging jaw or abdominal masses, and which are mainly the constitutional symptoms like night sweats, fever, and weight loss, which this patient whom I'm presenting today had actually presented with these. For lab and imaging, the peripheral blood counts are usually the first thing which usually we're able to detect with first. Of course, a bone marrow aspirate is mandatory, CSF evaluation for CNS involvement, and also an abdominal ultrasound or a CT scan, which usually have available in Kenya. So for the definitive diagnosis, the histopathology and the immunophenotyping, which usually shows either CD10 positive or CD19 positive or CD20 positive, or even the Ki67, which are usually near to 100%. Let's move on. With our patient, he actually had a Burkitt's leukemic phase, so that's why I also wanted to be able to define this, which is actually a rare presentation, whereby more than 25% of the bone marrow is infiltrated by the Burkitt cells, and it actually mimics an acute lymphoblastic leukemia, which the patient was actually presenting with. And the child may also present with pancytopenia, marked pallor, hepatosplenomegaly, and systemic symptoms, and also the unique diagnostic and therapeutic challenges which we were actually able to encounter, and which required the rapid initiation of chemotherapy and supportive care, and where the nursing team really worked well, and they did a tremendous job in identifying the challenges which the patient was presenting with. So this patient, just for background, particular study, we decided to pick on it because it was able to explore the complex of this patient, who's a 1-year-old male diagnosed with Burkitt lymphoma in the leukemic phase. And this patient in particular, presented with night sweats, just as we had defined in the clinical presentation. He also had a distended abdomen and also had a remarkable pallor, constellation of symptoms, which indicated the extensive tumor burden. And also a point to note for this particular patient, the child had a previous history of a confirmed malaria and also had moderate malnutrition.
I'm sorry, Celine, we cannot hear you right now.
Celine,
Oh dear. Can you hear me now?
yes,
Can you hear me now?
yes.
Okay, sorry about that. So I was just saying about the presentation of the patient with night sweats. We also had difficulty in breathing, which he was actually he presented this way because of the distended abdomen, of course, compression in the respiratory system. And he also had remarkable pallor and exhibited all these symptoms, which actually indicated the extensive tumor burden, which we'll be able to see in the presentation. And of course, had previous history of confirmed malaria. That's why I had actually presented on Kenya being an endemic area, and this also being a predisposing factor, risk factor to the patient having the Burkitt lymphoma. We may proceed. So of importance is that it's for us to be able to note that there was the obstructive nature of the tumor, which caused a disruption in the urinary output of this particular patient. And this was actually brought about maybe because of mechanical and also metabolic factors. And a blood gas analysis was done later, and which demonstrated a hyperkalemia and a metabolic acidosis. And this highlighted the metabolic derangements which are associated with the disease and its treatment. This patient had nephrostomy tube surgically inserted in theater through the interventional radiology team, which has really been instrumental in the care of oncology patients. And this was actually done in order to alleviate the urinary obstruction because of the mass, so the mechanical factors, and also the metabolic factors because of the hyperkalemia. But you'll be able to see we were able to manage that. Of course, chemotherapy was promptly initiated in order to address the leukemic phase following the initial diagnosis. And the lab findings also unveiled an elevated uric acid and lactate dehydrogenase level, which indicated the extensive cell turnover, and of which you're able to see that these actually landmarks of this particular case. We may move on. So these are the patient's information, and he's just a 1-year-old, 9-month baby, and that's the weight that was the weight of 9.5 kgs. We may continue. So he presented with a history of the history of presenting complaints. So this patient had, he came in through a pediatric emergency unit as a referral from Bali, Uganda, to Mama Margaret Kenyatta Hospital. Now, this is a hospital which is just within Nairobi, Kenya. It's most of the time the patients really go to the peripheral facilities and then they get to be referred for specialized treatment in Kenyatta. So he had a history of a persistent fever. He had night sweats, abdominal distension, neck swelling also, 2 months of apoptosis. He also had a lower limb swelling. He had facial puffiness and a significant weight loss over the past few weeks. And his parents had reported that he had also been unusually fatigued and irritable. We may continue. So for the past medical history, which is of significance, the first admission was in a peripheral facility in February 2025, and he was treated for pneumonia. The second admission was in March 2025, whereby he was treated for anemia and transfused. His blood group was O positive. He also had no significant illnesses or infections in the past apart from the confirmed Plasmodium falciparum positive test. And he was started on antimalarial treatment with good effect. He also had a history, which was quite interesting, of a reported left leg fracture, which was secondary to trauma like 3 months ago. But he was treated with antibiotics And it was, we're just querying that maybe it could have been osteomyelitis, because this actually happened in a different facility, and the documentation which we were presented with wasn't that conclusive. But of course, we were able to see the x-rays. He had no history of any persons managed for TB, so he had no TB contact. And he had also received blood transfusion once, as indicated in the earlier and in the admission history. He had no known drug or food allergies. So this is also some other important history to be able to note. He had been able to receive his immunizations as per our expanded program of immunization here in Kenya and also in Uganda. And his last vaccination was of measles at 1 year, 6 months. Milestones, of course, neck support. Sitting, he was able to sit down at 6 months, standing in support with support at 8 months, walking with support at 1 year. Now he is currently able, but unfortunately, currently he was not able to walk because of the fracture. We may continue. So the family social history, he was the last born in a blended family of 3 siblings. His first and second born siblings were from his father's side, from his previous marriage. The firstborn is 18 years old in high school, and the secondborn is a 14-year-old in grade 7. The mother is from Uganda, he's a domestic worker, and the father is Kenyan, who's a Mason. They had actually gone to Uganda just to visit the mother's family, and now that's when he became unwell, and then they were now coming back to Kenya for treatment. Can you hear me?
Yes.
Okay. So for the physical examination, we have the general.
We have lost you, Celine.
Okay, can you hear me now?
Yes.
Okay. So for the physical examination, he was generally pale on examination when he was coming out of the ward. And he was pale, he was emaciated, he was also febrile with 38.3. And his vital signs, of course, that using the pediatric early warning signs based, the heart rate was at 115 beats per minute, which it was actually a tachycardia. His SpO2 was at 95%, though he had mouth breathing. He also had a temperature of 38.3, just as indicated. He had mild distress, mouth breathing, and of course the pews indicated he was of moderate risk, warranting close monitoring. Then his cardiorespiratory for the cardiorespiratory assessment, the chest was clear. He had the normal heart sounds. The abdomen was actually distended with a non-tender mass. He had a hepatomegaly of 6 centimeters below the costal margin, the splenomegaly of 8 to 19% below the costal margin, of which I need us to be able to appreciate that he actually had a massive mass, an extensive mass, tumor mass, that is. The lymphatic system, he had generalized lymphadenopathy of both cervical, axillary, and inguinal. The neurological assessment, the AVPU, he was alert, and he was actually responsive to the environment, and the musculoskeletal assessment was normal, of a normal tone and power, apart from the joint swelling and tenderness. Thank you. So we'll continue. For the clinical findings, the lab findings, we had done a CBC, which revealed some cytopenias with a white blood cell count of 60.93, which was quite high. A HB of 6.7, a platelet count of 119, which was a bit low. And also he had the potassium. The potassium was actually normal. And you'll be able to see in the table, in the next table. Now for the peripheral blood smear, we can be able to see that the RBC had rouleau formation, normocytic, normochromic. The WBC now had actually indicated we are having a hyperleukocytosis of 84% of cells of normally sized atypically mature lymphoid cells. Of course, and also we had some mature lymphocytes, which are 10%, monocytes, eosinophils, as indicated. The platelets also reduced according to the peripheral blood smear. Thank you. We may continue. So those are our lab findings. You can be able to appreciate on the 26th of April, on the 30th of April, then on the 5th, on the 12th, and the 19th of May, because we usually do for our unit, usually do the labs every week, but in case there are any derangements, they're supposed to be done at least after any intervention, just to be able to monitor even if it's after within 24 hours or after every 48 hours. So you can be able to appreciate that the WBC count was quite high on admission. The ANC, as indicated, the HB was actually quite low. So we had to do blood transfusion, packed red blood transfusion, as we also monitor because of the hyperleukocytosis and also the probability of getting into TLS. So we also had to do the TLS prophylaxis. We may continue. We'll be able to go back in case of anything. So for the diagnostic imaging findings, just as I had informed you, we had an X-ray of the left ankle, which was done previously, and we were able to see, which confirmed that the patient had, it actually showed that it's like he had a chronic osteomyelitis. Of course, the abdominal ultrasound, which was done, confirmed as splenomegaly, which was further evaluated with the CT scan, and the CT scan revealed a bulky enhancing mass involving the right iliac fossa, extending to the retroperitoneum. And there are also signs of hepatomegaly and splenomegaly, which at least it was able to confirm. Now, later, we had the bone marrow spirit report, which confirmed that the bone marrow examination that we had a Burkitt lymphoma in leukemic phase. The lymphocytes were increased in variability and in the size. We had a typical immature forms of the lymphoblasts, which accounted for 91% of marrow cellularity. So for the management, this child was started on immediate emergency chemo, and he was started on chemotherapy urgently in order to reduce the tumor burden, because of course we understand that for hyperleukocytosis, the only way you can be able to reduce the lymphoblast is through the chemotherapy administration. And they were also supposed to manage the leukemic phase of Burkitt lymphoma. So the chemo regimen was supposed to be R-Copadem, to include the rituximab, vincristine, prednisolone, doxorubicin, methotrexate, cytarabine. But we had a multidisciplinary team meeting, which usually hold every Thursday. And because of the urgency of this particular case, we were able to discuss about it, and it was decided the patient to be started on the ALL high-risk regimen, consisting of vincristine, doxorubicin, prednisolone, elastogenase, and the IT methotrexate. And a point to note is that intrathecal chemo was also given in order to prevent a central nervous system involvement, and he was able to receive the intrathecal chemo. Hyperhydration was also instituted for TLS management at 3 liters per meter squared in 24 hours. So every single day he was able to receive it. We were able to give it through with normal saline and DNS, because it reached a point where the child was not really ready to eat. So also allopurinol was also administered, and at 10 milligrams per kg per day, while monitoring the strict input-output. Can we continue? So the emerging issues on 12th of May, the nursing assessment, because we usually do the pediatric early warning signs, especially for the very sick patients in acute room, daily, and according to the scoring. The nursing assessment indicated we were able to find that the patient had a tachycardia of a heart rate of 115 beats per minute. The fever was also at 38.3, and the respiratory was also at 95. On room air, though, there was some increased respiratory effort. There was some Kussmaul breathing. So the Pews indicated that he was in high risk, and which prompted escalation and urgent medical review, and of which the team was able to come in. We were able to do at least the fluid balance monitoring, input-output charting. Unfortunately, we were able to note that the patient had oliguria because we were doing hyperhydration, but on checking on the diapers, they were actually low. It was like one diaper in 24 hours. So despite adequate hydration, which is actually an early sign of acute kidney injury. So the BGAs were done. Of course, the patient was we were able now to identify that the patient had hyperkalemia. We had also metabolic acidosis because he had a low pH, low bicarbonate, and we also had an elevated lactate. May continue. So the metabolic acidosis also, it mainly usually amplifies hyperkalemia, making it more dangerous. So the immediate interventions, of course, we are able to start the patient on calcium gluconate IV in order to stabilize the cardiac membranes. We were able to give insulin and dextrose, also salbutamol for inhalation in order to shoot the potassium from back into the cells. And this actually had a good clinical response, and it was actually achieved. For the infection workup, we were able to do the blood cultures, of course, and the patient was also started on IV meropenem. Now, we involved the specialists. The pediatric renal team was able to come on board. They were actually able to come the very same day. And also the pediatric ICU teams also consulted. And after a discussion, it was decided that we need to involve at least the interventional radiology team, because after we were able to manage the hyperkalemia, at least now the patient, we were now able to see that he was having some urine output, but considering the mechanical nature of the particular tumor, because it was quite extensive and quite massive. So already over there, we already have an obstruction in the renal system. So that's why the interventional radiology team was engaged for nephrostomy tube insertion. Now on 14th of May, the patient was stabilized. He actually showed much improvement, and he began passing urine via urinary catheter, but we still required the nephrostomy tubes inserted. So they were inserted on the 14th in order to relieve the ongoing obstruction. And of course, we also continued the hydration, because you have to continue the hydration because the patient was already had previously hyperleukocytosis, and we needed to also continue managing for the TLS prophylaxis in order to restore the renal clearance. Let me continue. So this is just a diagram which I had decided to show here, just to be able to appreciate the nephrostomy tube insertion and how it usually looks like. And this has actually really helped quite a number of our patients. We may continue. So for the supportive care, the child required, of course, careful monitoring and prophylaxis for potential chemotherapy side effects like myelosuppression, which would predispose to febrile neutropenia, nausea and vomiting, mucositis, and all these were able to be monitored quite closely with the nursing team. Of course, blood product transfusion because of the anemias, and also pain management. He was also started, of course, on the supportive treatment in order to protect the systems during chemotherapy administration, like gastrogel, aldosterone, and nystatin, the magic mouthwash, which contains the lignocaine, the dexamethasone, chlorpheniramine, and also esomeprazole, to just be able to protect the gut because of the side effects of chemotherapy. For the nutritional support, he was given he actually showed, because of his significant gradual weight loss, he was able to receive nutritional support in order to ensure that we have adequate calorie and nutrient intake. And we were able to insert an nasogastric tube. And it was calculated that to get 110 mils 3 hourly, of 3 hourly intervals, though there are times when he was not able to retain that weight. So we were only able to give it like every 2 hours at 60 mLs every 2 hours. Of course, we started with the express breast milk because he was still breastfeeding. And initially he was started on the F75, then progressed now to F100. Pain management, we were able to follow the WHO pain scale. And he was already on morphine per oral at 2 milligrams per kg, and we're actually giving it at 4 hourly and consistently, with, of course, the adjuvant treatment of paracetamol with good effect. Psychosocial support, we are very grateful that we have our palliative care nurse who's consistently able to review him at least after every 1 or 2 days, and also for the parents, just for the social support, the psychosocial support for the parent. Let me continue. So in terms of discussion, I just wanted us to be able to see this slide and just be able to understand that there could have been other differential diagnoses. It could have been a diffuse large B-cell lymphoma, or a high-grade follicular lymphoma, or a B-cell acute lymphoblastic leukemia. And just despite the fact that, yes, we were able to do the BMA and confirmed it. Or the treatment, he had a confirmed diagnosis of Burkitt lymphoma in leukemic phase, and he was started on the ALL high-risk regimen, just as indicated, despite the fact that it delayed a bit, maybe because of system issues. The patient's clinical course, the patient was started, of course, on chemotherapy on the 3rd of May, and that was just like within a week after the patient had been admitted. the nephrostomy tubes were inserted on the 14th of May due to the logistical and medical insurance challenges, because when the patient was being admitted, actually, he didn't have the social health insurance fund, unfortunately, and it's usually required at least for the patient to, in order for the patient to undergo a surgical procedure. And if it is an emergency, yes, it can be waived. Though for this particular reason, the patient was, it actually delayed a bit, but at least it was able to be done within 48 hours, but it could have been done within 24 hours. So unfortunately, the patient died on the 25th of May this year at 8 a.m. And the lessons learned for our team was that the importance of supportive care is really important. And the multidisciplinary team consultation, just as we had, the nursing team was able to identify. I would say that the nursing team is like the first line of defense. They're like the first responders. And if you're able to identify an oncological emergency or a side effect, you can bring issues later on. If you're able to detect it early, then you're able to give an early intervention and prevent the complications, because many complications, like for example, if this patient went into AKI, acute kidney injury, then it could have been really hard for us to be able to reverse it. And even if we did, maybe morbidity would still have been high. So also the importance of application of the pediatric early warning signs and ETAT, which is the early triaging and treatment of pediatric patients in the management of acutely ill oncological patients is really, really important. Let me move on. And I think that's it. So these are just like the expected milestones for most of our patients, which we hope as a low-income country, someday we'll be able to get there. And in order to have less, the timelines of the waiting timelines may be able to be reduced from the initial presentation, the chief complaint, the diagnostic evaluation and investigations, that we won't have to wait so long. Of course, confirmatory diagnosis, we're able to receive the confirmatory diagnosis in real time, as in really in the expected time frame, in order for us to be able to initiate appropriate treatment. Of course, it does not prevent us from giving emergency chemotherapy, but it would always be good to have, definitive diagnosis. Of course, monitoring response to treatment is very important, and we were able to do that in our setup, which is something which we're able to commend ourselves for. Resolution of the presenting symptoms, and also follow-up and assessment for outcomes and case discussions like these ones, in order for us to be able to learn more and to be able to identify the gaps which we have in our systems, so that we can be able to address them. Okay. And I think that's it. Those are my references for everything. And yeah, and I am grateful for your audience. Now you may ask any questions or any clarifications. Apologies for my background and the challenges with sharing the presentation.
Yes, thank you very much, Celine, for the presentation. It has been very elaborate and educative at the same time. I now welcome questions for Celine or sharing experiences in regards to managing emergencies, especially for our children who come in when they are, at a late stage of disease, and we have to manage them with various comorbidities. Feel free to unmute and comment, or you can also use the chat if you're unable to use audio. But great presentation, Celine. Yes, Rahim.
Yes, I wanted to recommend for the good presentation and the multidisciplinary approach that they used in managing this case. It really shows that teamwork was involved because the patient presented with a lot of issues that were supposed to be managed by different disciplines. So throughout the case, I've seen the multidisciplinary team approach. I can recommend that maybe in other sites where we met similar cases, patient presenting with a lot of issues, we just have to use the multidisciplinary approach. Thank you, Celine, for that wonderful work. Thank you.
Yes,
Thank you so much.
thank you. Yeah. Thank you, Rahim, for that comment. Yeah, the multidisciplinary approach is really very commendable. Yeah, we have a question in the chat from Achit. I hope I'm pronouncing the name right. He says, good evening. Thank you for your efforts for caring for the child. It's unfortunate we lost the child. How were parents counseled throughout the course of illness? In one side, Burkitt lymphoma. I think it's in our side, Burkitt lymphoma is curable. And other side, these complications were there. Over to you, Celine. How were the parents counseled throughout the course of the illness, given this diagnosis?
Yes, thank you very much for the question. For our setup, we usually have the palliative team from the admission, from the patient, the time the patient gets to be admitted. And for this particular case, our patient was initially admitted in the pediatric general wards. Then thereafter, he was now transferred. Now, after we had the PBF, which actually confirmed that it could be a Burkitt lymphoma and around leukemia, because that was the differential diagnosis, he was now transferred to our ward. Now, before that happens, the palliative team is usually involved from the onset of diagnosis. And the team usually gets to counsel the patient, the parents actually, because now this is a 1-year-old patient, so he's not really able to converse. Now the palliative team, of which you have a palliative nurse, she gets to work with this patient or with these parents and the family all the way from diagnosis. And every single day, the moment that we get to notice that maybe the parent probably seems to be a bit anxious, then the palliative nurse will be called and gets to be informed to come and review the parent, or in case maybe they're having questions about the patient. So they get to be counseled all the way from diagnosis, and then we get to be able to work with the patient throughout. Now, the moment that we notice that the patient's outcome was not really, the prognosis would be poor, because as you can remember, when I was explaining about Burkitt's leukemic phase, it's actually rare, but the fatalities are significant. Now, the moment when you got to notice that the outcomes, because he was deteriorating, even after the nephrostomy tubes, he came up a bit, then he started now deteriorating once again. We had a family conference whereby we were able to call in the father, the mother, and the immediate relatives. We had an uncle, like a brother to the father, and a cousin to the mom. And they were able to come in, and we were able to inform them about the expected outcome and about the condition of the patient and what we could do. So that's basically how counseling for us usually works. But we're able to work with the patient consistently. And in case they have, like the mother was verbalizing, that she's worried about the outcomes, is he going to survive? And you can never stop giving hope, unfortunately, or fortunately. And that's basically how we managed it. And of course, now, just as I said, Burkitt lymphoma actually does have good outcomes. But now for our setup, especially for this particular case, who had Burkitt's in leukemic phase, which can actually be quite aggressive, the outcome was that fatal, unfortunately. I hope I've answered your question.
Thank you, Celine, for that elaborate response. I believe that you've answered our colleague. And yes, I should add that Burkitt lymphoma in leukemic phase is pretty rare and very, it's related with bad outcomes. The prognosis is usually very poor, and it's quite unfortunate that that child passed away despite all the efforts from the multidisciplinary team. But great work over there. Yes, Yeah, with still from Achit. He says, thank you so much for all you did. The end of life care. The end of life care at times helps parents cope, sends a positive message about healthcare that the holistic children that the children receive. Yes. So he's trying to emphasize the need for providing a good end of life care for our patients. I welcome any other questions. We have, okay, Aisha, you've raised up your hand. Over to you.
Thank you, Joan, and thank you so much, Celine, for your elaborate presentation. My one question is, were you able to, at one point, manage this patient in the ICU, or it was on ward? Because back here in Uganda, where I work from, we've always had issues accessing the ICU for our children, because in most cases, they share the ICU with the rest of the patients in the hospital. So did you think of, or you had challenges taking this patient to the ICU for proper, I know you properly monitored your child, like you presented, but I needed to find out from you. Thank you.
Thank you so much for the question, Aisha. We actually do experience the very same challenges. Our pediatric ICU has a 5-bed capacity. And of course, when it comes to acute lymphoblastic leukemia patients, any liquid tumor or any tumor as such, it depends on the availability of the beds. And I will confirm that the actually patients whom we've actually admitted to the pediatric ICU successfully, even to the main ICU. Our main ICU has, I think, a capacity of almost, I can't remember really well, maybe it's 25. But we have several ICU units in the hospital, almost 10. But now for the pediatric ICU, just 5 beds. So for this particular patient, it was a challenge. Although we'll appreciate the fact that he, after managing the hyperkalemia and the hypocalcemia, the BG is now actually normalized because of the prompt treatment, and that's what I always want to commend our nursing team, because of the quick response, and also because of incorporating the pediatric early warning signs. So at least the BGs, they actually it actually indicated that we had improvement. So thereafter, at least we were now out of the woods concerning the hyperkalemia and the metabolic acidosis. He was now stable. So now when the pediatric ICU team came in to see him, they were like, okay, now we're stable, so there's no need for ICU for now, but we still need to do an nephrostomy tube because of the mechanical obstruction of the massive tumor. But there are actually times when we've been lucky enough. So I think our stations are just the same resource settings, which are limited. And it just depends on, I guess, a patient's luck, if they're able to get a bed or not. Yeah. And maybe also because at least our patient had improved. But if it hadn't, or maybe, unfortunately, maybe our outcomes wouldn't have, we couldn't probably wait until the 15th. Yeah. I hope I've answered you.
Yes, I think you've answered her very well. Thank you very much. Do we have any more questions? Any more experiences from the team? Anyone wants to share anything, or ask a question, or add on to what Celine has shared? Yes. Yeah, and Celine, you're getting accolades in the chat from Courtney. She's commending you for sharing your experience and the great presentation. And if we do not have any more questions or supplements, we shall end our presentation here today. Thank you all to who have joined. And thank you, Celine, for the presentation. Thank you, Suzanne, for coordinating this. And I wish you all a great rest of your day.
Thank you. Thank you so much, everyone. And thank you for the opportunity. I really appreciate it. Thank you so much.